I'm going to talk about sickle cell disease and disease-modifying therapy, which is great for this venue because there's not a lot to talk about. I'm going to talk about 2 FDA-approved medications, hydroxyurea and L-Glutamine. Also briefly discuss the use of chronic transfusion therapy. I am going to leave curative therapies for another day. So in this disease, genotype really matters. For both hydroxyurea and L-Glutamine, randomized controlled trials have only been done in people with sickle cell anemia, those with SS or S-beta-0-thal. There's no good data to support the use of hydroxyurea in SC disease, and no data to support the use of L-Glutamine in SC disease. So we talk about hydroxyurea, we talk about the multi-center study of hydroxyurea, a study published in 1995, a double-blind randomized controlled trial. Again, only those with sickle cell anemia, about 300 patients were enrolled who had 3 or more crises per year, and it showed that hydroxyurea decreased crises, acute chest, and need for transfusion. But hydroxyurea benefits are not just limited to increasing fetal hemoglobin levels. It improves red cell morphology and deformability. It lowers white counts, retic counts, and adhesion molecules, and it's a local NO donor. It's a great drug, says Tony the Tiger. Another great thing about hydroxyurea is that it improves overall survival. So we know from 2 long-term observational trials, this one picture is from a paper from Greece, that people on hydroxyurea live longer than people not on hydroxyurea, and the results of this study are very similar to the multi-center study of hydroxyurea. The NHLBI recommendations for the treatment with hydroxyurea includes having 3 or more crises a year, having pain that affects quality of life, having severe recurrent acute chest, and having severe symptomatic anemia. Common mistakes I see with the use of hydroxyurea include non-initiating therapy in eligible patients. So even if patients have high fetal hemoglobin levels, if they clinically meet the criteria for hydroxyurea, we prescribe it, and failing to titrate to maximally tolerated dose. An ANC is between 2 and 4 while maintaining a platelet count of greater than 80,000. Another mistake is having too short of a trial of drug. We know that it takes about 3 to 6 months to see an effect of hydroxyurea. In order for it to work, patients have to actually take it, and we don't stop hydroxyurea during hospital admissions unless the counts are too low. L-Glutamine, the other FDA-approved medications, the mechanism of which is unknown. It's thought that it affects oxidative stress and decreases oxidative-related hemolysis, but none of the studies show an increase in hemoglobin or a decrease in retic count. We do know that oral administration raises the redox potential within sickle red cells. In the randomized controlled trial, there were 230 individuals with sickle cell anemia who were randomized to glutamine or placebo. They were excluded if they'd had recent transfusions, renal disease, liver disease, or pregnant or lactating. The results of that study show that the median crisis frequency for people on the placebo was 4 over the 12-month follow-up period, and for the L-Glutamine arm, it had decreased to 3. Similarly, the number of hospitalizations for sickle cell-related pain was a median of 3 in the placebo arm and 2 in the L-Glutamine arm. Another interesting finding is that the time till crisis was longer for people on the L-Glutamine arm than the placebo arm, so 84 days in L-Glutamine, 54 for placebo. One has to keep in mind there was a high dropout rate for this study, with 36% dropping out in the L-Glutamine arm and 24% in the placebo arm. This is a powder that you have to take with liquid twice a day. The cost of the drug is $3,000 a month for adults and $1,000 a month for children, so 20 times more expensive than hydroxyurea is. The side effects of L-Glutamine include constipation, nausea, vomiting, headache, and abdominal pain. Interestingly, in a study of critically ill patients without sickle cell disease who are randomized to IV glutamine or no IV glutamine, those who received IV glutamine actually died more than the people who didn't get IV glutamine. So for that reason, L-Glutamine supplementation should be avoided in patients with hepatic or renal impairment and should be stopped in those who develop hepatic, renal, or multi-organ failure. Unfortunately, we really don't have a definition of what renal impairment is or how bad it can be because there's no data on the use of L-Glutamine in people with renal disease. So I use L-Glutamine in patients who have been on hydroxyurea on good doses but continue to have crises. I also consider it in patients who can't tolerate hydroxyurea, and without data on variant genotypes and the cost of therapy, I don't recommend it for that population of patients. Chronic transfusion therapy is another disease-modifying therapy. These are the NHLBI graded recommendations for initiating chronic transfusion therapy, a pretty limited list: children with elevated TCD velocities and adults and children who've had a previous clinically overt stroke. But I also use chronic red cell transfusions in patients who have lots of painful events. This is a retrospective study of 23 adults from the UK who had a mean of 130 days in the hospital before starting chronic transfusions. That decreased by 20% in the first year after starting transfusions and almost 80% after being on transfusions for 5 years. This is another similar study in children demonstrating that in children you could decrease mean total visits from 6 to 2.5, decrease hospital days, cost of care. They do note that patients' ferritins increase, which is not surprising for patients who are on transfusion therapy. And so that is the scope of disease-modifying therapy in sickle cell disease, but I show you this beautiful picture of the horizon because things are changing, and we anticipated having a lot more therapies available to our patients in the coming years.